for the invitation, Zoli. We will speak today about hemoadsorption treatment of critically ill patients. And I will try to give you an overview from my perspective. I have to inform you about the conflict of interest in the very beginning of my talk. I'm not a physician. I'm a chemist and material scientist. And I'm the person behind the Efferon LPS technology and adsorber and medical device. So I am obviously biased, but I will try to stay as objective as I can during this talk. At the same time, I hope it will give you a new perspective on hemoadsorption, maybe, hopefully so. If we speak about hemoadsorption of removal of pathogenic substances from the patient bloodstream, this is how I would like to regard these substances based on their molecular weights and hydrodynamic radiuses, which are obviously connected to molecular weights, because for us as material scientists, it is pretty accessible to make porous material with some kind of controlled volume and radiuses of the pores. And this is the option how to make the membranes or adsorbents with a certain pore distribution, which can selectively remove or adsorb certain kind of pathogenic substances. And it's easy and fruitful to divide this spectra of substances into three subgroups, like small, medium, and large. Yeah, large, we can say anything what is larger than albumin and immunoglobulins. Small is small molecules normally, and water and ions, cations and anions, inorganic substances, and a huge continuum in the middle, medium-sized molecules. And a lot of these medium-sized molecules are the mediators of inflammation. And please have a note in the right side of the slide, bacterial endotoxin, lipopolysaccharide, molecule of bacteriological origin, and it has a very variable size. We'll speak about it later. It's hard to consider it in the certain part of this slide. So small molecules, this is what we normally remove when you are undergoing renal replacement therapy. Larger molecules, mostly for autoimmune diseases, liver failure and intoxication with albumin-bound substances. And the middle is what we normally deal with treating systemic inflammation and sepsis, the conditions which are mediated mostly via products of cytolysis of autologous cells or microbial origin, like LPS. And if we consider therapeutic targets in sepsis, it is worth recalling that everything starts with endotoxin, like the primary trigger, molecule of microbial origin, fragment of cell wall of gram-negative bacteria, a very powerful inductor of innate immunity, very powerful inductor of hypercytokinemia, and it is worth considering endotoxin as a viable therapeutic target in sepsis. And actually, this is what was, this approach was explored first in the extracorporeal treatment of sepsis almost 40 years ago in Japan. There were introduced first generation adsorbers for treatment of sepsis, which were targeting endotoxin, LPS molecule. Variable size in the bloodstream. It is very powerful, forms micelles and aggregates of variable sizes with the plasma. And the size of these complexes can be 20 kilodaltons to. This is the reason why making a porous is inefficient to bind such a molecule. And the first successful clinical approach to remove endotoxin in sepsis was built differently. So it has a surface immobilized polymyxin B molecule, which forms very powerful complexes, very strong complexes with endotoxin, thus destroying these supramolecular vesicles and removing it from the bloodstream via immobilization. Important consideration here, where does this obvious question is from the infection if we speak about gram-negative sepsis, but this is only a part of the answer because we as human beings have a bottomless reservoir, and that's why almost 30 years ago our gastrointestinal tract was called the undrained abscess of multiple organ failure. Yeah, and a healthy person can maintain barrier properties of intestine intact and keep this gut critical conditions, suffer from endothelial damage and gut hypoperfusion with the oxygen. And the first thing that fails here in the hyperperfused gut is its barrier properties. Thus, translocation of endotoxin into the bloodstream from intestine becomes inevitable in the very first hours of critical conditions. This approach to remove LPS in the sepsis patients was controversial. The evidence for it is controversial. There are positive results, there are negative results. I think there will be more positive results in the future. Promising approach despite being first generation, but it has inherent problem. This adsorbent, it has very narrow target, only endotoxin, right? In vitro bench tests of removal of broad range of inflammatory mediators, and you can see how terramyxin adsorbent is not removing them at no micro, no mesopores, which are capable of removal middle-sized proteins. And if this approach hemoperfusion, we should some stream. And this confirmation is very problematic. There are no reliable assays to do this. This is why the last version of Surviving Sepsis campaign recommends against polymyxin B hemoperfusion in sepsis or septic shock. This is the reality today, unfortunately. And these mixed results of first generation adsorbents, they inspired a new approach. What if consider as a main therapeutic target downstream cytokines, not the primary trigger, but secondary triggers. Like cytokines are key factors in cell signaling and immunomodulations. They are expressed as response to endotoxin and other DAMP and PAMP molecules, such as cytokines or other cell debris. They are very different from their biological function, but they are pretty much common from their size. And this makes it possible to make a porous structure with a narrow distribution of pores, which will be capable of their removal from the bloodstream. And I think this approach is very well familiar for you. The second generation of hemoadsorption in critical conditions, so-called anti-cytokine adsorbers. They have lots of micro and mesopores, huge internal porosity, efficient middle-sized molecule adsorption, but unfortunately they cannot do anything with the primary trigger, with the LPS. And the most recent meta-analysis, which investigate efficiency of anti-cytokine hemoperfusion in sepsis, they also consider this approach problematic. Like no efficiency in sepsis for this kind of adsorbent is noted. Possible reasons for these negative results. Well, we can have a spectrum of pessimistic and optimistic explanation. Optimistic explanation would sound like we need better ways to look for patients who respond for this treatment. So should we look for certain level of certain biomarkers or hypoimmune endotype of sepsis or certain stage of sepsis, certain locus of infection? We just need a better patient stratification who would benefit from anti-cytokine hemoperfusion. Or we can have more pessimistic explanation. So past generation anti-cytokine adsorber do not remove primary trigger of sepsis, endotoxin. This is like removing smoke without extinguishing fire. And this is like an inherent limitation, which will always have a subpar clinical efficacy in sepsis patients. I personally think that reality is closer to the right side of this slide. So this, to summarize how to approach to hemoperfusion in sepsis looked like before the introduction of our approach. So we had first generation, narrow LPS selective adsorbents, and we had second generation broad range anti-cytokine adsorbents. And each of them has its own set of strong and weak points. Like LPS selective adsorbents, they have affinity ligand to remove this very difficult to remove LPS molecule. This is a very specific task, and they can do anything besides that. They do not effectively remove cytokines, products of cytolysis, and other damp inflammatory mediators, which are, I think you all will agree, it's critical to remove them in sepsis patients. And we have a second generation of porous micromesoporous adsorbents, which cannot remove the primary trigger because of variability of its size. What if it would be possible to integrate these two sets of benefits in one single material? And this is actually the idea behind our approach. Furon LPS is the first product of such kind. So you can look on it as a second generation anti-cytokine adsorbent with a surface immobilized LPS selective ligand on these beads. So these beads, they are not bold like bold heads. They have this surface immobilized synthetic ligands, which form very strong complexes with endotoxin, and they are capable to remove it along with excessive cytokines. Important consideration here. So in reality, there is always a fine-tuning between these two sets of properties, because if we start with anti-cytokine porous matrix and we go for too much modification of its surface, we can make LPS selective efficient adsorbent, but this extensive modification of the surface will destroy the porous structure and we will lose the capability to remove cytokines. Or vice versa, we can have too little modification and the improvement of LPS adsorption will be very little, but cytokine adsorption will stay high. So we tried to sit on both chairs with this product, right? To introduce just the right amount of modification, to improve LPS adsorption, to retain cytokine adsorption. This is how this approach was studied and validated. This is a part of our R&D. Yeah, you can have a look on the middle diagram on this slide. The blue line is the amount of pores for untreated pristine beads, and purple is for surface modified beads with the immobilized ligand, which are a part of Eferon LPS device. So you see that this introduction of LPS binding ligands somewhat decreases the available volume of pores, but it is still pretty high. It is still a meso and microporous adsorbent, which retains the smaller pores, which are relevant to remove smaller proteins, such as interleukin-6 or other cytokines. You can see this huge amount of pores via scanning electronic microscopy. These are mostly macropores. The mesopores and micropores, which are relevant for removal of cytokines, are even smaller. And at the same time, this modification drastically improved capability to remove endotoxin. So this is the test which is a part of our quality control routine. Like each batch of adsorbent we are making is subjected to this test. You can see that initial solution upon the incubation with the pristine beads, endotoxin activity in this solution decreases considerably. But at the same time, Eferon LPS beads decrease this initial removal even more so it's a logarithmic scale. So it's about 2 orders of magnitude between untreated beads and surface modified beads. Is based on these beads is a pretty standard. Can be used as isolated hemoadsorption or in combination with any kind of extracorporeal circuit, renal replacement, cardiopulmonary bypass, ECMO, whatever you want. And the girl on the right, she is the youngest patient who benefited from Eferon LPS hemoadsorption. She was 1 day old when she received this treatment. And you can see that the cartridge on the picture is a smaller version. It's a pediatric version of the cartridge. It is not yet accessible in European Union, but we will hopefully make it possible in the next year. And currently there is a large study for pediatric sepsis. We are enrolling patients in, and the results are very reassuring. If we will look for the indications for hemoadsorption, hemoperfusion for the critically ill patients, I tried to align the possible indication on this slide in accordance to impact of endotoxin. So on the right, we have sepsis, where have critical conditions which are mediated mostly through smaller molecules, or myoglobin, as in rhabdomyolysis, which are most often have no impact of endotoxin. in the middle, where most often goes along with the impact of endotoxin, especially if we keep in mind the translocation from the gut. But nobody usually calls this condition sepsis, right? Or somebody does. It's an additional question. And this gray zone in the middle is a huge amount of potential indications for hemoadsorption. And the question is what kind of hemoadsorption would be mostly beneficial for this patient? Is it anti-LPS hemoadsorption, or is it anti-cytokine hemoadsorption? And this is how indications as per positioning of these devices looks like. So anti-cytokine adsorbents try to cover all range of these critical conditions, like one size fits it all. But my personal opinion that it is problematic to use them for the conditions in the right picture of the slide because of their inability to remove the primary trigger, LPS. The situation looks different for terramyxin, which interacts with the primary trigger only, so most probably it would be beneficial for gram-negative sepsis, but at the same time, there is no rationale or less rationale to use them for patients with hypercytokinemia, with the liver failure, with rhabdomyolysis. And this is exactly the goal and the idea behind the Feron LPS adsorbent. So it would be the device to cover this subsets of patients where it is already sepsis or maybe not yet sepsis, but educated guess, the best educated guess physician can make that most probably their critical condition is mediated via endotoxin and cytokines. If we will look for IFU and indications for interferon LPS, you can see that it's very clearly stated that it's indicated in sepsis of verified or suspected gram-negative etiology, but also any kind of elevated levels of endotoxin and cytokines is also indications for use. And also important thing to keep in mind, because this is a broad range activity adsorbent, potential concern is that it will remove antibiotic drugs, because the antibiotic drugs is still the first line, and we are speaking about adjuvant treatment of sepsis, right? So it's very important not to hit the first line treatment via our adjuvant treatment. And there is currently an ongoing clinical study of antibiotic drug removal via interferon LPS. It's a clinical study, not a bench study, not an experimental study, and it is designed to assess it's asking two questions. First, what is the total organism clearance of antibiotic? And second, what would be an adsorber clearance and how are they compared to each other? And the preliminary results, not the final one, but still they exist at the moment, that total clearance via interferon LPS is below 10% of total body clearance. So it is not zero, it exists, but it is pretty much negligible if we compare what human body does with these molecules. And the biggest question is how good this idea, because, you know, there is a huge amount of nice ideas in biotechnology and physiology and medicinal chemistry, which just don't work at the end. And important thing about interferon LPS that there is an evidence behind its use in sepsis and septic shock. There was a multi-center randomized clinical study run on almost 60 patients, which were randomly distributed into two subgroups. One of them received standard of care treatment without any type of anti-LPS or anti-cytokine hemoadsorption, and another received two efferon LPS hemoadsorptions. Main inclusion criteria was patients with abdominal sepsis complicated with septic shock, and a very narrow time window for the intervention. So within 24 hours after source control surgery, and within 12 hours since the onset of septic shock, since the start of norepinephrine infusion. So no any specific biomarkers, no endotoxin or interleukin-6 levels were considered to be inclusion or exclusion criteria. And the main endpoint was hemodynamic one, so abrogation of septic shock. Baseline characteristics of the patients in this study, you can see that SOFA score was about 7 points, so not 12, not 14, but still they were pretty severe patients. And as you will see soon on the outcomes in the control group, outcomes were pretty severe. Time from onset of septic shock to the first hemoperfusion was even shorter than 12 hours as by protocol. It was 5 hours in reality. Duration of hemoadsorption each was about 5 hours also, 300 minutes. Less than 20% of all treatments were run in combination with CRRT. The majority of them was run as isolated hemoadsorption. And last but not the least, the occurrence of premature circuit clotting was very low, less than 2% after heparinization of the circuit. And these are the main results of the study. Left is cumulative hospital survival, and we have cumulative mechanical ventilation weaning, and right, the primary endpoint, cumulative shock recovery. You can see that septic shock and mechanical ventilation duration was almost 2 times shorter in the efferon LPS group, and chance to successfully wean from this aggressive organ support was almost 2 times higher in efferon LPS group. Cumulative hospital survival was higher in efferon LPS group, but unfortunately the study was underpowered to show the statistical significance for 28-day survival rate, but still it was observed. This is how cardiac function was improved. This what means that septic shock was resolved, like the arterial pressure was increasing alongside with a decrease of required norepinephrine dosage. Pretty quick, you can see that despite the 2 hemoadsorptions which patients underwent, even after the first one, the effect was observed between 0 and 24 hours time points. SOFA score was decreasing in the efferon LPS group, and for the control group, it was looks like that it was decreasing, but as you saw on the previous slides, the mortality rate, 3-day mortality rate in the control group was almost 60%. So the most severe patients could not make up to 72 time point, and that's why this survivor bias makes the impression of improvement of SOFA score in the control group. You can see that dotted line for last observation carried forward gives another picture here. And this is the changes in biomarkers level for these patients. all the important inflammatory biomarkers confirm the improvement of vital function we saw right before. So endotoxin, interleukin-6, C-reactive protein, procalcitonin, leukocytes, they all go down in the treatment group. And this is different what happens in the control group. And take-home messages from this study, I would like to emphasize once more that it is not a silver bullet, not a last resort therapy. So we have a narrow time frame for the intervention since the onset of septic shock or since the ICU admission, whatever makes the time point 0 here, right? And neither blood culture tests, no certain levels of biomarkers, including endotoxin, were found to be necessary to enroll benefiting patients. How the longer is not necessarily the better. Like median hemoperfusion duration was just 5 hours and 20% of patients were combined with CRRT, rest of them isolated hemoperfusion. Both ways are fine. I think how a physician feels here, what is more convenient to him is the most important consideration. And the results, the cardiac, respiratory, and renal function respond first to the FRON LPS hemoadsorption. Septic shock, mechanical ventilation, kidney injury are more likely to be resolved and their duration will be shorter. But long-term survival improvement depends on multitude of factors. At least we can see that antibiotic removal is pretty much negligible here, and we do not put the patients under additional risk, decreasing the exposure to antibiotic drugs, the first line of therapy. So to summarize, 3 generations of hemoadsorption, where are we now? So 40 years ago, Japanese scientists said, let's extinguish fire, let's remove primary trigger of sepsis. Then another approach was, let's capture smoke because people die from asphyxia, right? In the fire. Let's remove excessive cytokines, downstream mediators. And each of these approaches has its strong and weak points. But I think now in 2020s, it is finally an opportunity to do both things together, extinguish fire and capture smoke. Thank you very much. My monologue is over and I would like to answer your questions.
Thank you, Ivan. It was a great lecture. Thank you very much. I don't know if anyone has any questions. I have several. I had several, but you answered many of them. So, do you have a question? So, we have a question. If a patient has rhabdomyolysis and septic shock, is it better to combine cytosorb with efferon, or efferon is efficient to treat rhabdomyolysis and sepsis also? What is your opinion?
We have some anecdotal cases for pediatric patients where FRON LPS alone was sufficient to do both things together. And we have a bicentric randomized study of FRON CT, which is not the same thing as FRON LPS. That's anti-cytokine adsorbents based on this technology without surface modification in rhabdomyolysis. And they were also found to be efficient in shortening duration of renal replacement therapy and ICU stay in rhabdomyolysis, toxic rhabdomyolysis patients, not the traumatic ones. I think this makes it possible to treat the patient with a septic shock associated, sepsis-associated rhabdomyolysis of afferent LPS alone. But you see, I'm very careful here. We don't have evidence yet.
Yes,
But
the most typical,
yeah.
Yeah, and the most typical sepsis-associated rhabdomyolysis is the result of streptococcal infection, and it is a gram-positive bacteria. So maybe it doesn't have LPS, or just a little amount of LPS.
That's an interesting topic to discuss because if we will refer back to Lasso study, which was run on the patient with abdominal sepsis, and the idea behind this patient selection was to have a patient with a gram-negative sepsis, yeah, because of gut. But in reality, you can see that these patients yielded a lot of gram-positive blood cultures and mixed blood cultures.
Mm-hmm.
You see in the table 1 here in the lower part of it.
Yep.
And despite that, results are positive. We also have a lot of anecdotal evidences like case report, real-world data that patient with a soft tissue infection, with streptococcal infections, they are benefiting from this treatment. Exact mechanism, I don't know. Either it is via removal of gut-derived LPS, which probably plays an important role in pathogenesis of these conditions, or via removal, non-selective removal of cytokines and exotoxins of these pathogens. So I think that we are not confined to gram-negative sepsis with this adsorbent. This is what I try to say, and we have data to support this claim, but still it is worth of evaluating it in more careful and rigorous way.
Okay, thank you. Anyone else? Yes, we have one question.
Hello, my name is Kanat. I would like to ask you a question about, so we have a molecule which can bind these exotoxins and cytokines. Why don't we have this in an IV medicine, like we just infuse it? It opsonizes the cytokines, the exotoxins, and
So do you hear Chanad?
I heard the first part of the question.
Okay,
but,
okay, so I translate.
Thanks.
So the question is, why don't we have an injection, an infusion that works the same, just like this porous and ligand-like hemoadsorption treatment, by opsonizing the cytokines and the LPS or other exotoxins?
Well, it's a philosophical question, but I would answer it in the way that, I have some kind of background of medicinal chemistry, but mostly I'm a polymer chemist myself. And it's easy to achieve a binding with a target molecule in medicinal chemistry. Like preclinical stage, when you have some kind of opsonizing, it's a simple thing. But when you would try to do the same thing in the human organism, when you have to have a proper pharmacokinetics, proper pharmacodynamics, when you will have a metabolism which will try to do something with your opsonizing agent, this is the most difficult part. So have an in vitro binding is a simple thing. But most drugs fail because of metabolism and because of pharmacokinetics, how to have the proper concentration of therapeutic agent in a proper tissue. And this is the hardest part, actually. Yeah. So I think 5 to 10% of drug candidates who are successful on the preclinical stage make it to the third stage with this hard part. Yeah, and this is actually where making medical devices is much easier than making drugs, because we don't have metabolism, we don't have pharmacokinetics to solve here. We just have the surface and the right in the proper tissue in the blood for a well-known duration. You can adjust by your own hand, and this is why this approach can be much easier to implement.
Okay, thank you. Anyone else? Okay, so then I have questions. I'd like to ask you whether you have a cartridge for children, but you answered it in the lecture. However, we do not treat children here in our hospital, but it will be great if hospitals, ICUs for children can use this cartridge also. My second question, do you plan to have a standalone machine, just like cytosorbents, that's called Purify, I think so, or because you mentioned that Efferon LPS can be used as a standalone cartridge without CRRT, but if we have only CRRT machines, we have to use in this double modality with renal replacement therapy and hemoadsorption. But do you plan to construct a machine for standalone hemoperfusion or hemoadsorption?
Currently, we don't have such plans. We are a much smaller company than Cytosorb. I want to be frank with you. We have a limited amount of resources, and we'd better focus them somewhere else. Machines are mostly accessible here.
However, B. Brown will have kits sets for standalone hemoadsorption, so I hope we can use it from next year also.
Right, but my point was that you are free to do whatever you like with the modality of the treatment, pre-filter, post-filter, isolation. We don't see any correlations with outcomes. Whatever is convenient for you, this is how you. I think the subjective impressions are more important here than the direct impact on the human
Yes, but
organism.
if a patient doesn't need renal replacement therapy, then it's much more cheaper if we use only hemoadsorption without renal replacement circuits.
That is true, yeah. That was the idea, to target the patients early who don't maybe need this RRT yet.
Yes, this would be my third question. What do you suggest? When should we initiate hemoadsorption therapy? As early as we can, as possible. I know. Okay. Do you suggest any protocol to evaluate the saturation cartridge? Because we know we use many Cytosorb cartridges, and we see that it is saturated during the first 12 hours in most cases, and we measure procalcitonin or bilirubin pre and post filter regularly, but it is just on us that we decided to measure. Do you suggest any protocol?
It's a complicated question. I would give you some ideas now how to approach this question. So no, I think no simple answer, no protocol to do it is accessible. But what you have to keep in mind, of course, saturation is occurring. So clearances in the initial hours of hemoadsorption would be higher than the clearances for subsequent hours. You can see this very clearly for antibiotic removal. Yes, so difference between inlet and outlet plateaus in about 5-6 hours. right? Pretty much independently of molecule we are removing. At the same time, you can see that size of human albumin, which is its concentration is few orders of magnitude higher than cytokines and endotoxin. Its hydrodynamic radius is not that different from the inflammatory biomarkers. And I think that this saturation we are speaking about, it occurs mostly via adsorption of fibrinogen, of fibrin already, of adsorption of albumin, of bigger proteins, which are excessive here. So if you would need longer duration, you would better switch cartridges. But at the same time, you can see that 5 hours hemoadsorption yielded a lot of benefits for the patients. So at the same time, you can see that cardiac function responds very quickly to this treatment. And in many cases, you could titrate the dosage of hemoadsorption looking on the improvement of cardiac function, not on the level of biomarkers.
Okay, thank you very much. And my last question. We are physicians, you know. Should we be aware of molecular weights of antibiotics? Because you mentioned vancomycin and meropenem. But what about the other antibiotics we use? If they are absorbed, they will be ineffective, maybe.
Yeah, this is the biggest concern. And I think we should all think about it. And we are studying it. So unfortunately, there is no simple correlation with the molecular weight, with the size, with the hydrodynamic radiuses. You should consider the protein binding, the volume distribution, and still I could not find simple correlations. I think it should be studied independently and monitored independently. That's why we initiated this study. We started with these two molecules because there is a lot of data in the literature. We can compare us with the cytosorb. We can have them as a control. But of course, new molecules will be a part of this study. So the protocol is nice, is working, and of course we will use it to evaluate more molecules. But for you as a physician, I am afraid that therapeutic drug monitoring is a thing you cannot close your eyes on. But still, you can see that it's not that scary. So if we would trust this data, doesn't look like you remove a lot of antibiotics here.
Yes, it
But
seems it depends on the timing also.
Yeah, that's true. And you also have concentration dependent or time dependent antibiotic. You have different correlates of efficiency. So it's complicated. I agree here. But this is also, I think, a part of the question to how long hemoadsorption should run. Like of course, it yields some risks. And of course, you should not make it longer than you need. And if you can have the result fast, maybe you'd better to stop it early and then repeat after redosing antibiotic.
Okay, thank you, Ivan. I think our time is over. And thank you for your time. Thank you for your lecture. I think it was great. And I hope we will meet soon.
Oh, we will.
Okay, thank you very much.
Thanks a lot.
Have a nice weekend. Have a nice time in Riga. Thank you very much.
You too. All the best. Goodbye.
Thanks. Bye.